Hi, it's a pleasure to be with you today to talk about advanced CF lung disease. And today we're going to talk about progress and some of the challenges that we face to address the issues. My name is Joe Paluski. I'm at the University of Pittsburgh Medical Center, where I am the Associate Chief for Clinical Affairs, with my clinical focuses being cystic fibrosis and lung transplantation. So over the course of the next few minutes, what I'd like to talk about are the following. Airway disease and CF. We'll do a brief review of the causes and treatment options. We'll then talk about infections and how that drives the decline in lung function and leads to advanced lung disease. Next, we'll define advanced lung disease, so we're all clear on how we approach that and when that label is appropriate. We'll talk about identification of advanced lung disease, the complications that occur, and the various treatment approaches. And then lastly, guidelines for referral for lung transplant. So first, what is the cause of CF airway disease? In these schematics that were kindly provided by Stuart Elborn, it really highlights how CF lung disease develops, starting on the left-hand panel with the CFTR protein channel in the diagram on the far left. This channel is responsible for allowing salt and water to move across the surface of the cell so that it stays wet, as shown in this little droplet in the upper left corner. The schematics below show what happens at a microscopic and a large view of the airway. So normally our airway is lined with a specialized cell type that has these little finger-like projections that protrude from the top of the cell. Those are bathed in a liquid, and their synchronous beating allows for the movement of mucus and anything else that we inhale out of the lung. If we look at the right two panels, what you see is if you look inside an airway with a bronchoscope, the airway is glistening and moist and sort of an orangish color. And then if you were to look at a section of the lung on the far right, we have small airways with a hole in the middle. That's normal. The lung has airways that allow for air to move in and out, and there's no mucus or other things obstructing that airway. If we contrast that with cystic fibrosis, again, walking from left to right, on the lower left, you see that there is a CF protein, but the protein doesn't work. Those little blue balls are unable to get across the surface of the cell. And as a result of that, as shown in the diagram, there's the evidence of dehydration. The airway becomes very much like a desert. So instead of those finger-like projections being able to beat and move in a liquid layer, they basically get stuck in mucus, and that allows for an environment where bacteria and viruses and other things that we obtain from the environment can get stuck and cause infection. On the right two panels, you see what the inside of an airway with significant CF lung disease looks like. The airway is very beefy red and swollen, and that's due to infection and inflammation that causes the airway to react. On the far lower right, you see, again, a smaller airway, and instead of being open and filled with air in white, it's filled with a mucus plug. And those mucus plugs are areas of infection that cause blockage of the airway and cause patients to have cough and shortness of breath and other symptoms. So with this as the cause of the CF airway disease has been determined over the last 20 or 25 years. Now we think we understand the cause or pathophysiology of cystic fibrosis lung disease. So I'm going to walk through this from top to bottom, thinking about the major parts of the cause over time. So the CFTR gene defect is a genetic inheritance of a defective protein, and that abnormal CFTR protein is responsible for moving salt and water across the airway. The defect in the protein causes a defect in movement of salt and water, and the airway surface becomes liquid depleted like a desert, as I showed in the previous slide. When the airways are dehydrated, there's delay in what we call mucociliary clearance, which is the mechanism by which mucus is moved out of the lung. As a result of that mucociliary clearance defect, we have a mucus obstruction on the far lower left that allows the environment for infection. That infection causes inflammation or white blood cells to migrate into the airway to try and fight infection. And over time, this leads to the airways becoming dilated and the development of what we call a bronchiectasis. This vicious cycle of mucus obstruction, infection, inflammation over time leads to scarring in the lung and what we call advanced CF lung disease, as we'll review in a few minutes. So based on this understanding of the cause of CF lung disease, a number of treatment options have been developed over the last 30 years that have markedly improved survival in CF. If we start with the airway surface liquid depletion, two options really are hypertonic saline and mannitol by inhalation. So these treatments help to restore a liquid layer and improve mucus clearance. For mucus obstruction, it was recognized long ago that exercise airway clearance devices like a vest or flutter or acapella and the inhaled treatment DNase or Pulmozyme are helpful for relieving mucus obstruction and allowing mucus to move out of the airway so it's easier to breathe and lung function is preserved. Lots of antibiotics have been developed over the last several decades for infection, and those are used by both inhalation, oral, and intravenous to treat patients with CF when they have infections. If we then move back up the cascade, the newest kid on the block, if you will, is treatments that address the abnormal CFTR protein, and CFTR modulators like ivacaftor or the triple drug combination, ivacaftor, tezacaftor, will help restore the abnormal CFTR protein and allow for better ion transport. The future in the treatment of CF is the development of gene editing or gene transfer, where there's actual replacement of or correction of the genetic defect. Ultimately, this would be a cure for the airway disease in CF if initiated early in life, and that is certainly the goal of research efforts by the Cystic Fibrosis Foundation and some industry partners. If we think down at the bottom of this paradigm, advanced CF lung disease, we'll talk about the treatment options, but lung transplantation remains an option for individuals who develop advanced CF lung disease despite maximal medical therapy with the other things that we've outlined. So what about infections in CF? What types of infections are there, and what can we do about them? Well, one of the earliest infections we see in CF, as we see in lots of people, is viruses. So respiratory syncytial virus, or RSV, influenza, and the COVID virus, or SARS-CoV-2, are all seen in individuals with CF, oftentimes early in life. And many of these infections and others will help to set up an environment that's ripe for other infections by causing airway injury. Vaccinations are really critical to prevent these infections, and we're all very pleased to see the development of an RSV vaccine that we hope will be helpful for infants and other children, including those with cystic fibrosis. Another broad category of infections in CF are a variety of different bacteria, and the specific names are not critical, but essentially what happens over time in many individuals with CF is that airway infections occur, and some of those infections become chronic. So we attempt to eradicate bacteria when they're first identified. Sometimes that is effective, and sometimes it's not. In many of our adults with established disease, infections have been there with specific bacteria for decades. And so we try to control the bacteria, knowing that we can't eradicate them. And then Other pathogens or infections that we see in CF are mycobacteria. These are relatives of tuberculosis, and funguses like Aspergillus. And thankfully, there's been the development of treatment for many of these over time, knowing that we continue to have need for additional therapies. These infections cause what we call pulmonary exacerbations, and these pulmonary exacerbations cause progression of the lung disease. So what is an exacerbation? I think many of you are familiar with this, but it's essentially defined as a worsening of symptoms or a reduction in lung function that's associated with inflammation in the airway and sometimes through the whole body, and what we call physiologic changes that lead to a loss of lung function over time. So many individuals are doing fine. They get a worsening of their infection. Lung function takes a step down. With treatment, we hope that lung function will return to normal, but in some cases, it doesn't go all the way back to normal. And these cycles of infection over time lead to scarring of the lung, such that there's a irreplaceable or irreversible loss of lung function. Inhaled therapies to target antibiotics can help reduce the frequency of exacerbations, as can treatments like hypertonic saline, Pulmozyme, and the new CFTR modulators. So many of the treatments that we have are designed to help prevent or reduce the frequency of exacerbations so that we can preserve lung function. So that's really an important approach that's been recognized over the last 10 or 20 years for how we can preserve lung function in CF. CF lung disease, unfortunately, is progressive for many patients. And this registry slide, this is from the Cystic Fibrosis Patient Registry, where there's a comparison of lung function versus age in a group of patients cohorted or grouped by birth year. So if you take the red line represents a group of individuals who were born between 1992 and 1996. And this was so very early in the development of CF therapies. Many patients had normal lung function in the far left at age 6, 8, 10, 12. And then there was a reduction in lung function over the next 10 to 20 years, such that in that cohort or group of patients, by the time they reached age 30, their lung function on average has gone from 90 down to 75. So a 15% loss of lung function by age 30. Thankfully, with new therapies, if you look at the subsequent groups of patients, that is, who were born at later time periods, like say, for instance, in yellow, individuals born between 2002 and 2006, that progression or worsening of lung function early in life has really been prevented by a lot of the therapies that we've developed. So this is very promising, and particularly if you look at the last group at the top, the blue line is a group of patients who were born between 2012 and 2016, and they had continued to have normal lung function at age 9, in contrast to patients who were born, say, in 1992 to 1996, that already had a reduction of lung function very early in life. So we're very optimistic that we will have reduction in lung disease severity over time with advance of CF therapies, and that we will see fewer individuals with advanced lung disease, certainly over the next 10 to 20 years. And eventually we envision that individuals with CF will have preservation of lung function for a lifetime and live a normal lifespan. This graph on the right, I just want to highlight the group of patients who have very severe lung disease, that is an FEV1 less than 40%, that's in red. So if you look at this registry slide, what you see is that in patients who are younger, say between 5 and 15, that red bar is very small. So it's a very tiny number of patients who have severe lung disease. And that's terrific news that most patients get through the pediatric early years with quite good lung function. If you look as patients age into their 20s, 30s, 40s, 50s, and 60s, that red column or red bar becomes a little bigger. So it highlights that severe CF lung disease is generally something that occurs now in adults, not often in children. So this is an overview that I think nicely provides some context on what happens with lung function over time and how we wish to address it. This is from the guidelines that we wrote on advanced CF lung disease back in 2020. And if you look on the left-hand side, we look at lung function starting with good lung function at the far left. And then the disease progression over time demonstrates a reduction in lung function that occurs at variable lengths of time. So while patients have good lung function in the blue shaded box, our approach is really to provide standard CF care using all of the tools that have been developed to preserve lung function. When patients have progression of their lung disease, we start thinking about them having advanced CF lung disease, or ACFLD, and we continue standard care, but we also think about things like referral for lung transplant, management of the comorbid or other conditions that occur in advanced CF lung disease. We think about psychosocial screening and caregiver planning for how patients are going to be provided their needs as they develop more disability. We have increased attention to things like palliative care for anxiety and depression that are oftentimes associated with significant lung disease, and then planning in some cases for end of life and how much aggressive care patients want when they have very severe disease. At some point in the lower right corner of the schematic, we think about transition to lung transplant, and we'll talk about that a little more in the future. So this disease progression generally occurs over decades. It's not a process over weeks or months. It's a process over decades. And that's thanks to the therapies that have been developed. So how do we define advanced CF lung disease? We all agree, based on this consensus work that we did, that individuals who have a FEV1 less than 40% predicted should be defined as having advanced CF lung disease and should have additional testing to identify things that are associated or problems that can be hidden in patients with this degree of lung severity. Other criteria that we use to define advanced CF lung disease are patients who've been referred for lung transplant for one reason or another, or individuals who have various markers of severe disease. And I've listed most of them here. So any patient who's been admitted to the ICU for lung failure, we would label as having advanced CF lung disease. Patients with high blood carbon dioxide or hypercapnia, patients who need extra oxygen would be defined as having advanced CF lung disease. Pulmonary hypertension is a condition in which the pressures in the right side of the heart become high as a result of chronic lung disease. And that we know that patients with pulmonary hypertension and cystic fibrosis have a shortened survival and have, by definition, advanced lung disease. If people have a markedly reduced functional status or a 6-minute walk test distance of less than 1,300 feet, we similarly label them as having advanced CF lung disease. So these screening tools and considerations are designed to try and identify patients early and not get surprised when patients develop complications, and try and prevent these complications as much as possible. So for example, if we identify that somebody has low oxygen saturations, either with exercise or with sleep, providing extra oxygen through a little nasal cannula can oftentimes help prevent complications like pulmonary hypertension. So there are other factors that we'll consider, and I won't go through these in detail, but suffice it to say that people who have other illnesses like worsening malnutrition or diabetes, or a problem in the past with a collapsed lung or bleeding, those individuals also tend to have a more rapid progression of lung disease, and we need to monitor and be extra vigilant to make sure we're not missing anything. So I want to review just a few of the complications of advanced CF lung disease and some of the treatment approaches that have been developed. So we think about advanced disease as this FEV1 under 40% of normal. How can we go after this to try and preserve lung function and prolong survival? Well, we know that individuals with any cause of advanced lung disease will get deconditioning because they don't exercise and aren't as active. And associated with that, they have reductions in their airway clearance. So pulmonary rehabilitation is a formal program where individuals can get structured exercise 2 or 3 times a week to try and maintain their muscle function and also help with airway clearance. As exacerbations become more frequent in advanced lung disease, we oftentimes will use antibiotics more frequently, and not uncommonly we'll use steroids to help dampen inflammation and preserve lung function. Hypoxemia is a complication defined as low oxygen saturation. We need to be attentive to this. And oftentimes when patients have FEV1s under 40% of predicted, we'll monitor oxygen saturation at home during sleep with a small portable monitor. And if the saturation goes down during sleep or with exercise by walking in the clinic, for example, we'll provide extra oxygen to help prevent other complications. I mentioned hypercapnia is high carbon dioxide. We can screen for this with blood tests, and it's important to do so because it is a marker or indicator of advanced lung disease and would be an indication to try something called non-invasive ventilation, which is use of a mask connected to a portable machine that would help rest the lungs and provide better breathing during sleep in particular. Pulmonary hypertension, we treat with a supplemental oxygen when the oxygen is low, and we have some so-called pulmonary vasodilators or medications that will help open up the blood vessels and improve the pressures in the heart as treatment options. And then lastly, respiratory failure is a condition where the lungs have approached failing. Individuals with respiratory failure are on oxygen all the time and also are oftentimes have high carbon dioxides. So when that occurs and it's particularly severe, the options are a ventilator or a respirator that's given through the mouth and consideration of lung transplant. One of our goals is to try and get patients moving towards lung transplant, if that's a treatment options, prior to the development of severe respiratory failure and the need for a respirator. This is what advanced CF lung disease looks like on a CAT scan or an X-ray of the lung. These are slices through the lung, and what you see are these big cystic lesions, so holes in the lung, if you will. In the top view on the left-hand side, you see mucus sitting in one of these large cystic areas, and the other areas are either blocked with mucus or have significant thickening of the wall. So this is a condition that we try hard to prevent, but when it occurs, we have to think about what are treatment options. So lung transplant has been developed as a treatment option for advanced lung disease from cystic fibrosis, emphysema, pulmonary fibrosis, and other diseases. It was first developed in the 1980s and has been more widely available since the 1990s. The goals of transplant are to prolong life and improve the quality of life. And for many individuals with advanced CF lung disease, this provides opportunity for both. Having said that, we reserve transplant for individuals who have received maximal medical therapy and their disease has progressed to a severe state despite the maximal medical therapies. And the reason we do that is transplant is not a perfect solution. It has its own set of complications and problems. Consistent with that, we know that the median survival for individuals with CF who get a lung transplant in the current era is about 10 years. So clearly this is not a perfect solution. The range of survival is highly variable because there are sometimes complications that develop that really shorten survival after lung transplant, including things like infection and rejection of the new organs. Thankfully, many patients will live decades after transplantation, particularly those with CF, who have a better survival after transplant than individuals transplanted for pulmonary fibrosis or emphysema. So we have 30-plus-year survivors who've had many years of high quality, clearly longer life than they would have had without a transplant. We've made progress in lung transplant, but have a long way to go. We're working on preventing complications and then treating those complications when they do occur. And that's led to improved survival in individuals after transplant over the last 20 years. What does that look like? Well, this is a very dramatic example. This is an individual with cystic fibrosis in his 30s who had essentially destruction of the one lung. So you see a big difference in the chest size between the two lungs. The right side is essentially destroyed. The left side's very diseased. He received a double lung transplant several years ago, and this is what his X-ray looked like early after transplant, with essentially normal looking clear lungs. And he's done well now, 5 years after transplant, with normal lung function and really clearly benefited from transplant. As a result of the challenges we have with advanced CF lung disease, we've been concerned for a long time that a number of individuals have not been referred for transplant or have not had that opportunity presented to them. So we convened a consensus group of experts in the US and international sites to make referral guidelines. These were published in 2019, and this is a figure from that slide. What's shown on the left-hand side is the lung function, FEV1 % predicted, as one goes from 100% down to 30%. And then on the right-hand side, we presented suggestion, recommendation for how we should think about transplant as a treatment option. So when individuals have pretty good lung function, that is greater than 50%, less than 100% of normal, we think about discussing on an annual basis how things are going in general. Is lung function been preserved or is it sliding? And at least introduce the concept of transplant as an element of clinical care. When patients get below 50% of normal lung function, we think it's important to discuss lung transplant on an annual basis with a focus on thinking about what the barriers might be to transplant. So really working hard to address things like control of diabetes if it's present, optimizing nutrition, optimizing muscle function with regular exercise. At FEV1 under 40% predicted, we start screening for markers of disease severity. And if we find other markers of disease severity beside FEV1 less than 40, we recommend that patients get referred for lung transplant evaluation. As a hard stop at the lower limit, the recommendation is that any individual with an FEV1 under 30% predicted should be referred for transplant, because we know that that group of individuals has a shortened survival. And if transplants to be pursued, it should be pursued at that time rather than delayed until the individuals are too sick for transplant to be a safe option. When patients are declined for transplant for whatever reason at one transplant center, we recommend a consultation with a second lung transplant center, because the criteria for transplant vary from one institution to another. So the other parts of these referral guidelines, if we summarize what the recommendations are: earlier introduction of lung transplant as a potential treatment option rather than waiting until patients are critically ill. We strongly recommend that CF programs and providers should not determine candidacy. There remain a number of misperceptions or misunderstandings as to who is a transplant candidate and who isn't. We really strongly would like the transplant programs to make that decision, because they have the expertise to know who is and who isn't a transplant candidate. Our early referral is important because it allows time to address modifiable barriers and get patients in the best possible shape to have a good outcome after transplant. It's important to remember that referral, evaluation, and listing for transplant are separate processes. So just because one has a referral for transplant doesn't mean that transplant is going to happen anytime soon. And this schematic highlights the various aspects of what I call the transplant journey. The first step is referral. So records are sent from a CF program to a transplant program. The transplant program reviews the records and then will typically invite the individual to come for an evaluation, to meet various team members and undergo some testing. At that point, there's a decision to either defer transplant for the current time while working on optimizing other medical conditions, or proceed with listing for transplant. Once patients are listed for transplant, the wait times vary from days to months, rarely more than a year in the current era. So once on the list, the opportunity is available for identification of a donor and for individuals to proceed with transplant. So there are multiple steps in this journey, and beginning the journey doesn't guarantee getting to the end of the journey. And we have individuals who were referred for transplant whose disease stabilized and lived years to, in a few examples I can remember, more than a decade between the referral process to actually undergoing transplant. So we like to think about transplant as one of the treatment options, but not necessarily something that we're going to pursue immediately. Knowledge and addressing barriers and understanding of what's involved is really important. So we're focusing very much on this in both CF programs and transplant programs with resources that have been developed by the CF Foundation. And their website and the UNOS website are very valuable for information on lung transplant and what's involved. So the CFTR modulators have had a dramatic effect on advanced lung disease, and I'm just going to highlight that. This slide shows an overview of the development of the CFTR modulators over the last 15 years. This schematic from Dr. Collins in 2019 highlights on the 2012 approval of Kalydeco as a treatment for individuals with CF and a G551D mutation. Then at the end of this in 2019, just 7 years later, we had the development of elexacaftor, tezacaftor, ivacaftor for individuals with the most common F508 del mutation. So now we have approximately 90% of individuals with CF eligible for one of the CFTR modulators. And as a result of that, we've seen significant improvements in lung function and slowing of lung disease progression. Importantly, we weren't sure how well these modulators would work in people with advanced CF lung disease. And so some registry studies, and one I'll highlight was published from the French experience, really demonstrate that these modulators can have a dramatic effect even in individuals with advanced lung disease. So in this registry study, they followed individuals with CF and FEV1 under 40% predicted, that is advanced lung disease. On average, the group had an FEV1 of 29% predicted, so really quite low lung function. After beginning the triple drug combination, they had an increase in their FEV1 between 11 and 14%, and their nutrition improved with weight gain of 2 to 4 kilograms. These results are comparable to what was seen in patients with less severe lung disease, patients who were oftentimes on long-term oxygen and what we call non-invasive ventilation. Those really very severe patients were less likely to have an FEV1 improvement, but many had significant symptomatic improvement. And perhaps most dramatic from this registry study, many individuals who had been proceeding down the transplant pathway were able to delay transplant and come off the list. So this schematic shows what happened to this cohort of 245 patients who had severe lung disease at the beginning, prior to the initiation of the triple drug combination. 15% had been referred for transplant, and 6% were on the lung transplant list. So 21% were so-called in the transplant pathway. At the end of the 6 months of follow-up, 96% were not considered for transplant because they were sufficiently stable. The number who were referred and on the transplant list went down significantly. And so the number in the lung transplant path went from 20% down to 2%. This experience has been echoed and repeated across the US in many of our CF centers, where individuals with advanced lung disease who started on triple drug were able to delay transplantation and continue with their medical therapies without pursuing transplant. So as a result of all the treatments that have been developed over the last several decades, we have improving survival in CF. Much of this is related to therapies that were developed a decade or two ago. We're just now starting to see in the registry at the end over here, the survival in the cohort of patients who are born in the most recent era between 2010 and 2020. We anticipate survival at least into the 40s. And with new therapies, we think that this will be even higher. By recognizing advanced lung disease and referring for treatment options like transplant, we hope that survival will continue to improve. So in summary, advanced CF lung disease develops over time in most individuals with CF, albeit at varying times. CFTR modulators will markedly delay the progression of CF lung disease. We've seen that now consistently, and it's likely that in the future, individuals who are started on CFTR modulator at a young age are likely to live into their 50s and 60s before a lung transplant becomes something that they would need to consider. Having said that, we need to recognize advanced lung disease and address its complications because that's critical to improving quality of life and prolonging survival. And lastly, for individuals who have progressive advanced lung disease despite medical therapies, lung transplant is a good option for many. So I hope this has been informative and given you a sense of advanced CF lung disease, of the challenges and issues we face, and the treatment options that lead us to believe that the future is really quite promising, thanks in large part to basic and translational and other investigators and support of agencies like the Cystic Fibrosis Foundation and the National Institutes of Health. Thank you.